you. PK, guys, thank you so much for having me today. So let me add an S at the end. I've had more than one worst case, if that's possible by correct English. Um, so I have nothing to disclose except I've been there. These are all my cases. I have been there. I have been part of it. When I say the fellow was holding it, that's not true all the time. Most of the time it was me also. So I always like to start with a quote just to kind of wake you guys up. I know it's been a long day already. So this is what I remember being taught when I was a fellow. If you haven't seen this complication, you haven't done enough cases. And so that's how I kind of did my fellowship, saying, well, I need to do more cases, I need to learn more, I need to experience these complications myself. I'm going to try to change your theory about this today. So my spin on this is Yogi Berra, any baseball fans, but Yogi Berra has some great quotes. You can observe a lot by watching. And we're going to look at this and say, let's not talk about you have to experience a complication. Let's talk about being prepared. And let's pay attention to be prepared, and let's learn muscle memory and good habits in the lab so you don't have to experience what I'm going to show you today. So this is my smallest perforation, if you're allowed to use that word with the word perforation. 62-year-old male came in from mid-LAD CTO, right radial, left CFA axis, and everyone's saying, well, isn't this an endovascular symposium? Why are we talking about the coronaries? So this is our axis shot. FYI, there are two things wrong with this axis shot. One is you don't see the tip of the sheath. And two, why are you not taking the axis shot picture through the micropuncture sheath? Why are you taking it through the 6 French sheath? But this is a coronary case, so coronary guys do things a little differently. So we got a successful LAD CTO. Everyone's so happy, high fives all around, great job. Let's go and have a drink, dinner. Patient says, my left side's hurting. Your back? No, my belly. That doesn't make sense. Usually it's the back that hurts, right? We all think about retroperitoneal bleeds. So you can see on this picture right over here. Now this is not a standard picture. You would not take this picture doing a groin shot to look at your sheath positioning. But he was having pain over there, so we took the picture over here. Contralateral axis was gotten as well, and I think that's more to be safe. And another picture was taken, and what you have here is you have a lateral circumference artery perforation, most likely from the micropuncture wire, right? So the micropuncture wire is a dangerous wire. It has to be watched every time it goes in the body. It cannot be just put in because it feels good. It'll feel good in a dissection. It'll feel good in a perforation. It'll feel good going through bone, okay? So what we did is, and this is something you have to know how to handle, and this is not difficult to handle. This shouldn't be a problem where you have to call in, Dan over here and say, well, come in, cut this down. What are we gonna do here? So what we did is we took a Renegade catheter. We have a wire up our iliac, okay? Always want to have access. We could have put an 035 wire up here. I think this was an 018 wire. You just want to have your sheath with better control. A Renegade catheter, a microcatheter is put into the artery, and then we delivered Concerto coils from Medtronic coils. And you can see the picture after that the perforation has been sealed now. Patient went home the next day, did absolutely fine, no complications from it afterwards. But always watch your wires. So what I tell my fellows when I walk in the room, I said, if this is on standard fluoro, you're already making a mistake. I may use a little extra fluoro, 15, 20 seconds per case. I put all my cases on low fluoro. So the end result is you're gonna get less radiation, and I watch my wires everywhere. And I'm a radial coronary interventionalist, predominantly. I watch my wire go up the forearm every single case. I never let tactile sensation guide me on the way. Know your lab's equipment. We were just chatting in the speaker's room about what kind of coils you have, where you have them. Also know where they are, okay? So the big problem in this case is no one knew where the coils were. So it took us like 20 minutes to find the coils. So, I mean, we had the situation tamponaded. It wasn't a dangerous perforation like a coronary perforation where you go into tamponade, but know where everything is in your lab. So case number 2, a not so small perforation. A 76-year-old patient of mine comes in with unstable angina, comes in on Friday night. Of course, everything happens on Friday night and Saturday, right? Tortuous iliacs. We said, let's take a 6 French 45 sheath up. We advanced it over the 035 J wire, the long one, of course, just a regular one that comes with our, when we open our cath pack. And we had an external iliac artery perforation. And what happened was, and I'm showing this picture as a still image purposely, we didn't feel the resistance properly. And even though we were watching the catheter go, the sheath go over the wire, we were not cognizant how much resistance there was. And basically the 6 French 45 centimeter went right through the external iliac artery. And this picture You don't see the flow. Well, the problem is sometimes you won't see the flow because so much blood has come out by the time you take a picture, it's either sealed or it's hitting blood and you're not seeing the blush come out. So what do you see in this picture that would say, well, something's wrong? Otherwise, this picture looks totally fine. There's one thing on this picture that's a sign I want you to learn today and never forget, because if you ever see this again, you should know exactly what's happening. Right? Look at the bladder. Right? So this is retroperitoneal bleed with a displaced bladder. So fixing this is not rocket science. Everyone should know how to do this. We put a balloon up, we tamponaded it, we got a covered stent, and it was fine in the end. But you want to pay attention to these things and look for signs. You're not always going to see blood extravasating like out of the artery and have a beautiful picture that you can see. So whenever you do, especially for iliac interventions, but whenever you're doing anything, make sure you have your A-line pressure hooked up, right? Because that drop right off the A-line pressure should be one of the first warning signs you get. Don't chalk it up to sedation. We always say, oh, we just gave Versed, we just gave some nitro. Just really pay close attention to it. If you're doing an iliac intervention, a planned iliac intervention, and you're going up one side, make sure you have a pressure on the other side. Make sure you're prepared so you can watch something happen. So when you're inflating the balloon, the first thing you're looking at is you're always watching your pressures. Know what to look for, which we just showed. Use a stiff wire when ever advancing a long sheath up. So I never use the J wire anymore. I'm either using a Glide Advantage, a short Amplats, or a Supercore. I never take a long sheath up the iliacs into the aorta unless I have one of those wires, because those wires will keep your sheath centrally located in the artery, will not let them divert off path and perforate. Have emergency equipment handy in the room. So large diameter sheets and catheters, covered stents, of course, a coda balloon, or there's some other balloons as well that are aortic occluder balloons. And what we did is this, in this case, we balloon tamponaded the iliac. I went up the other side, put a coda balloon over through a 12 French sheath into the distal aorta, got control, and then was able to get my equipment and fix the vessel. And always be aware, I use heparin for all my iliac cases, the same way I use heparin for all my CTOs. You can reverse it, angiomax, unfortunately you can't. So anytime I'm doing a case where a perforation could be devastating, as opposed to an SFA where it's not that dangerous, as opposed to a non-CTO where perforation is very rare in the coronaries, I always prefer to use heparin. Case number 3, respect getting access. So those are my perforation cases, but I like to share knowledge, so I don't want anyone to have these complications. This one may be unavoidable, and you may see this. You may happen to you. This is a standard access, ultrasound-guided, fluoroscopy-guided access in a patient with very bad PAD, and we tore this artery apart. And this was a micropuncture wire. It felt so smooth going up, no resistance, floored it the whole way up, and this is what we ended up with. So what did we do wrong here? We took a picture again, and then I took a picture again. So I lost the profunda, and then I lost the SFA. So lesson learned, don't keep on taking pictures. Come up and around. You know you're going to have to fix it anyway. Get control from around. We did that as our next steps. And this is the same way when you take that picture, you think, oh, it's going to help me. I thought I want to see the angle. Can I see the dissection better? The truth of the matter is I made this worse, right? I destroyed the flow to the foot by extending the dissection flap and covering up the SFA and the profunda. So I think everyone can imagine what you do. You just come up and around, wire profunda, wire the SFA, confirm your placement of where your SFA wire is with the microcatheter. I confirmed the profunda. Very gentle balloon inflation. Now I can see the dissection, right? I dissected on the way up. So theoretically, the blood flow should heal this. It would not have healed it before, right? Because that was almost a tear, but it would heal it now. So we did a very gentle balloon, brought the patient back 6 weeks later, and you see that the dissection healed nicely. This is one of my favorite cases. This is something I teach the fellow. I think they've probably heard it ad nauseum from me every time we had micropuncture access. So let's start from the end of the case. What is this? This is your micropuncture sheath destroyed. So what happened is on the exchange, I pulled the micropuncture sheath from the hub, not from here, right? If you pull it from here, you can tear it. If you pull it from here, you're less likely to tear it. So I pulled it from here in a very difficult calcified groin, and it tore. I tried to get it because it went into the body. I tried to go get it with a clamp, and I couldn't pull it out. So it ended up in the body. One good thing is one of my old attendings taught me never use a short J wire for access. So I always use long J wires for my access. So I had a wire up in the thoracic aorta. So this micropuncture sheath just was on that wire. It didn't come off the wire. There's nowhere to come off. I had so much wire support. So to make it simple, we just snared it the other side, put a 4 French glide sheath in from the left side, pushed it out around. Didn't realize it wouldn't go through the 6 French sheath I had in there. So we upsized to a 7 French bright tip. And I no longer wear my wedding ring in the cath lab because I lost it once now, but that's me. And we pushed it out through a 7 French bright tip. And we used the bright tip so we knew where the tip of the sheath was, so we could see that it was coming out nicely. And we externalized it and obviously stopped the procedure there. So always grab that micropuncture sheath from the sheath, not the hub, and always pull slowly. And if you lose it, get that clamp so quickly, cut down a little bit. Okay, we can use scalpels. I know there are some surgeons here, but the endovascular fellow, you can use a scalpel, cut a little bit so you can get the sheath and grab it. And that's where I also made a mistake. I didn't cut. I just kept on trying to get the clamp in there to pull it out, and eventually I pushed it in. So I'll end it there with this one little thing about what I've learned, what we've learned. Take your time. I do fluoro and ultrasound guided for every single axis, including my radials now. Not fluoro for radial, of course, but ultrasound for everything I do now. Always use the long wire. And sometimes an 18 gauge, the Cook needles are better than micropuncture. So when I have very difficult groins, very calcific, repeated access, prior angioseal, prior per close, prior pre-closes, I will also go with the Cook needle under ultrasound guidance. I think it's as safe as a micropuncture. And I think what happens is the micropuncture is more prone to dissect, especially in these frequently accessed femoral arteries. And so I'll go back to the 2 quotes I left you with, and I'll stop here. So I don't think you need to see every complication. I think you just need to hear about them. Like no one here should ever have that micro sheath complication now, right? Pay attention to your wires, watch where you're going. And you can live a lot by watching. And so I'll leave it with that.
Thank you, Dr. Kukar. I think any questions for Dr. Kukar?
So I have a question. So if in terms of algorithms of management, I know you talked about what is it called, having large wires and stuff. If these fellows are going to do iliac interventions, let's say, what is and iliac interventions are done in the OBL, they're done everywhere that we know of. So what is the minimum equipment they should have available to them so that they can bail themselves out? And what's the algorithm? I think that's a very important question for them.
Yeah, no, can you guys hear me okay? Is it on? Yeah. So, I think it's hard. I'm actually just putting a new lab together in Queens, and I'm grappling with the same thing with limited space. What equipment do I need? So, in 10 years, I've used a coda balloon once, but in that one time, it saved the patient's life. So I think you need an aortic occlusive balloon if you're going to intervene in the iliacs and if you can do common iliac bifurcations. And I think you need to have covered stents, of course. So you need to have your ATRIMs, your ICAS, something to seal up your perforations so that you can end there. And then I think the stiff wires, it's more of a style. I happen to like the Glide Advantage a lot and the Supercore. I don't think you need a Supercore and an Amplat stiff. I think you just need one very stiff supportive wire. And I think that with some larger sheets, like 10, 12 French sheets to put your aortic occlusive balloons in. Dan, does that sound reasonable?
Yeah, absolutely. I think for the Cook, so it's interesting when you are putting the aortic occlusion balloon, you can do it through the 12 French sheath like we talked about. A lot of the times you worry about how you're going to close that vessel when you're done. On label, pre-closed ProGlide is 9 French, but it does work up to a 12 French sheath. So it's, when you guys are thinking about ways to bury yourself out when you have the occlusion balloon after you fix everything, you should keep that in mind. I think the 2 points I did want to make about your case is, the first case seems like a little thing, but you really, you should be commended at it. Like a patient's complaining about some abdominal pain, the fact that you went back and took that picture, that's the difference. Otherwise, that patient goes to the recovery room and they continue to bleed into the rectus sheath, and you can lose a tremendous amount of volume even into the rectus sheath, and then they can end up doing well. So I think listening to the patient and taking it seriously, I think, is always going to be important. And then the last case, what I've never seen a micropuncture sheath do that, but you could totally see the events that led up to that, like very scarred groin. You heard about common femoral endarterectomies with patches, and you're trying to shove this sheath into it. And as a result, it's just scrunching at in the front before you end up trying to pull it out. So that's something that even throughout you're worried about. One caveat I will say to the 18 gauge puncture for some of these scarred groins, I use it all the time as well. I love it. If you don't have the bevel correctly, it will snare off your stiff angle glide wire right off the tip of your 18 gauge needle. So that's probably the one scenario where I don't like stiff angle glide wires. Thank you very much.